Yeah, hello, this is Peter Roux. I'm a neurosurgeon from Philadelphia in the United States. I'm going to talk about brain oxygen monitoring. I'm going to focus on traumatic brain injury, although this can certainly be used in other pathologies. The data is just not as robust. I do have a consulting agreement with Integra. That's one of the manufacturers, and a safety monitor for Boost 3, which is a large trial. Why brain oxygen? Well, there are no effective drug therapies for traumatic brain injury. There's great variation in care. And what we tend to do is use guidelines that are based primarily on control of intracranial pressure and cerebral perfusion pressure, and in essence, the avoidance of secondary cerebral insults. Now, you do see an improvement in outcome when you're compliant with the guidelines, but there's a ceiling effect. You get about 80% compliance and you start to see an increase in mortality. But they're fundamental goals in neurocritical care. What we're trying to do is predict who's going to do well. In other words, select patients for appropriate treatment, primarily to then identify and prevent secondary cerebral insults. And as we manage them, balance extracerebral and intracerebral physiology. So physiologic parameters are important in care. And this is a list of some parameters that we used in PROTECT, which is probably one of the most well-performed phase 3 trials on traumatic brain injury, although no benefit was seen with outcome. So monitoring is critical to get these physiologic parameters. Monitor is derived from the Latin word to warn, and specifically when you're looking at oxygen, clinical findings do not allow us to reliably detect hypoxia or hyperoxia, and hence some kind of tool is necessary to define it. In traumatic brain injury, we primarily focus on intracranial pressure. And there's no question, high intracranial pressure, particularly if refractory to care, is associated with mortality, but not necessarily outcome. Our whole concept of monitoring was challenged from the BEST TRIPS trial that Randy Chestnut performed in South America that suggested with or without an intracranial pressure monitor, the outcome was the same in traumatic brain injury. It's perhaps not surprising because in essence, two therapies which was primarily the same were being used. But Randy, to his credit, organized a consensus conference that tried to address these concerns, and certain recommendations were made, and that is that the primary impact of this trial was research-oriented. And the primary question that we didn't know was actually what defined intracranial hypertension. Perhaps more importantly, we recognize that intracranial pressure is really the tip of the iceberg. There's a lot more happening below the surface. And importantly, features such as classic ischemia, which we might be able to detect when we use a combination of ICP and blood pressure monitoring to look at perfusion pressure, is not the only thing that happens in traumatic brain injury. There's microvascular ischemia, which comes about through diffusion problems or changes in mitochondria that lead to the pathophysiology and the brain dysfunction. In addition, a lot of these changes occur before there's a rise in intracranial pressure, as can be seen in this microdialysis analysis. So we need multimodality monitoring, which is really defined as the simultaneous collection of data from multiple sources to try and give us information or complete information about the organ concerned. Several years ago, there was a consensus conference which was organized by the Neurocritical Care Society and the European Society of Intensive Care Medicine, and this addressed oxygen monitoring. And there was a suggestion that brain oxygen monitoring not only was useful in predicting outcome, but also in the titration of medical and surgical therapies. But the data for that was of fairly low quality. So how can we monitor brain oxygen? The gold standard would be PET. We cannot really do PET in the ICU unless we're in Cambridge. So we use monitors, and a variety of tools are available, as you can see here. Lycox is perhaps the most frequently used and is the biggest body of literature. Why is this important? When you have glucose and oxygen, you get 38 ATP. And ATP is necessary to maintain neuronal membrane integrity. In the absence of oxygen, you get 2 ATP. So one can clearly see the energy dysfunction that occurs. The brain consumes about 3.5 mils per 100 grams a minute of oxygen. And oxygen function and oxygen and brain function are interrelated. So brain performance decreases when you reduce brain oxygen. This is seen at high altitude or other oxygen-depleted environments where cognitive and motor performance is impaired. Conversely, as you increase oxygen, you can see an improvement in cognition. This is a study done with hyperbaric oxygen, and if you measure factors such as BDNF, you see an increase, and this can affect dendrite plasticity. So why in traumatic brain injury should we monitor brain oxygen? Various studies using PET, MRI, microdialysis, jugular venous saturation have demonstrated, in essence, that hypoxia can occur in the absence of a perfusion abnormality. So simply knowing blood flow or perfusion pressure would underestimate or miss hypoxic events. On the other hand, too much oxygen is bad. It's a U-shaped curve. So hyperoxia can aggravate outcome. So we need to have some tool that allows us to monitor what's happening. How that effect might occur may depend on when the hyperoxia is present. This is a study looking at stroke, where you have hyperoxia during the ischemic phase is protective, but during the reperfusion phase can actually aggravate the brain damage. So as I mentioned, there's several monitors. The Lycox is the most frequently used and the greatest body of literature. It's a fairly simple device to insert. It's sitting in the white matter, as you can see here on the head CT scan. Importantly, a CT scan is necessary once you've inserted the device because you want to know where it is relative to the other pathology, because this does affect how the data is interpreted and the robustness of any data. If it's in normal white matter, and this is a study we did where we correlated oxygen with xenon CT blood flow, it does give a representation of global oxygenation, even though it is a local monitor. The slide has been a little distorted by the browser, but what it's trying to show is what is brain oxygen a measure of. And it seems to be a relationship between cerebral blood flow and the difference between arterial and venous oxygen, or AVTO2, so oxygen tension. Having said that, it's not a measure of blood flow. And if you look at oxygenation in the brain, it does reflect respiration. This is a very elegant study done in mice that were walking. You see an increase in oxygen levels in locomotor centers, and that increase persists even if you block neuronal activity or functional hyperemia. It correlates with respiration. There are many features or many factors that influence brain oxygen. Here on the bottom, we can see what we can measure in an intensive care unit: blood pressure, blood content, and so forth. But there are many local factors that influence oxygen in the brain. What is the consumption? What are the oxygen diffusion gradients? How many capillaries are there, etc.? Not surprisingly, lung function affects brain oxygen. The worse the lung function, reflected here by the PaO2, FiO2 range, the worse the brain oxygen. Blood transfusion can improve brain oxygen, but it's not an inevitable increase. In some patients, you might see a decrease. Exactly why that happens is not clear. But importantly, while anemia is a controversial topic on how best to treat it, anemia coupled with low brain oxygen is associated with brain outcome. So the effects are important to study. Following resuscitation in the brain, even when you can restore or achieve adequate perfusion pressure, in about 30% of patients, you might still see hypoxia in the brain. Importantly, in this side, intracranial pressure can affect brain oxygen, but it's not an inevitable occurrence. D is perhaps the most important representation of what we'd like to see, because as intracranial pressure increases in this patient, you see brain oxygen go up, and then it starts, as the ICP continues to increase, decrease. This may then define the threshold in that particular patient where ICP can be treated, i.e. one can create precision medicine. Brain oxygen might also be decreased during shivering. Perhaps that explains why hypothermia does not work. So it doesn't make a difference to outcome. And the short answer is yes, it does. Low brain oxygen is associated with mortality and unfavorable outcome. So more than ICP, which is only associated with mortality. It's an independent marker of poor outcome. So the Marshall CT score, the anatomic abnormality, the Patchy score, the physiologic variable, and the burden of brain tissue hypoxia are all associated with poor outcome. There are a variety of therapies that can be used to treat compromised brain oxygen. I don't need to go into those in detail. Nothing is unique. They're all simple processes of care that can be performed in an intensive care unit. Is it associated with outcome? Yes, it is. These are early studies that were historical controls or concurrent cohorts. And when pulled together, you see an improvement in outcome in patients that get brain oxygen-based care. So this led to BOOST 2, which was a phase 2 study to try and demonstrate that at least physiologic differences were made when patients receive care based not only on an ICP monitor, but also brain oxygen. The treatment was in 4 different tiers, depending on what the intracranial pressure was or what the brain oxygen was. But this was a fairly complex process of care study. The primary objective was really to demonstrate that the burden of hypoxia would be reduced. The secondary objectives were to say that you'd not see adverse events and it was feasible to do the study and it might make a difference to outcome. Well, it answered the primary question. The burden of hypoxia was reduced when brain oxygen care was rendered. In addition, there were no safety issues and the protocol was not violated in any difference between the ICP group and the PBO2 group. But outcome was slightly improved, although the study was not powered to detect an outcome difference. So the implications of BOOST 2 is that we can do complex process of care studies. Recruitment was a challenge in the study, but safety was not an issue. The data for monitors can make a physiologic difference, and if we correct physiologic parameters, we can have a positive impact on outcome. And hence, that has led to a phase 3 trial. So BOOST was approved for study by the NIH in 2017. The target enrollment is just over 1,000 patients, and this is sufficient to detect 10% absolute improvement in good outcome. The primary objective, as I said, is to demonstrate benefit where you use brain oxygen monitoring coupled with ICP monitoring, and so brain oxygen-based and ICP-based care compared to simply ICP-based care alone. Currently, over 60 patients have been recruited. There's been some delay as the COVID pandemic has affected enrollment. There's been a consensus that has evolved on how best to manage patients, and this is published in Intensive Care Medicine from the Seattle International Brain Injury Consensus Conference. There also is a study that's about to start in France that's comparing the similar strategies in the same way as BOOST 3 is doing. 300 patients are expected to be enrolled in that trial. So when you use a brain oxygen monitor, you go from simply using a hammer and a nail that can do a lot more in terms of patient care. You get the Swiss Army knife for care. Just remember, the monitor alone doesn't save the patient. Rather, it's the wise application of the data from the monitoring that can make a difference. Thank you.